We are now recording. This is Alex Preker, Dr. Alex Preker of Columbia University and Mount Sinai Hospital, formerly of the World Health Organization and the World Bank, dealing with health issues and economics and public health globally. And so I have to thank Stan Shawn. Stan Shawn was the person who made the connection. And Alex grew up here in Vancouver and in the Shaare Zedek as well. His father was, if I'm not mistaken, a member of Shaare Zedek. Jack Boxer said that you were classmates. I'm not sure if that was in medical school or somewhere else. But first I want just Alex to introduce himself and explain why his experience is relevant. I did get one question a little earlier over email is, why do we get an expert from New York City? And I think one of the things that this series sort of teaches us is that we have a lot of expertise in our wider network, and in that wide network, we are doing our best to bring that wisdom. And so, I mean, unfortunately, it looks like we're going to be in here for a little while, and we hope to be able to use the far corners of our expertise. And I'm really, really excited that
King.
So Alex, please introduce yourself, and then I'll get to the first question.
All right, great. Well, thank you very much. And this has been quite a quick voyage since Stan first contacted me. I'm delighted to be able to share some of my experiences with the congregation at Shaare Zedek. I do have some fond memories of Shaare Zedek when I was a child, and I grew up in New Westminster. My father, Shaare Zedek, was the synagogue that he used to go to. We lived in New Westminster, and so of course we were not so accessible to the synagogue, and certainly you couldn't attend the high holidays and be observant at the same time. But I do have some fond memories, and I do visit every so often. I've been there recently because my father was buried in Queensboro, and so I do go there for his yard site. He died between Rosh Hashanah and Yom Kippur, and so we often go there on the Sunday when you have the visit to the graves. And it happens to be that Stan's father and my father died exactly the same day, so we have the same yard site. So it just it's a connection there. Anyways, in my background, I grew up in Westminster, went to UBC, did medical school in UBC, finished off at McGill, practiced for a few years, and then at some point I decided I wanted to do something more broader and international. I went to London School of Economics, did a PhD there, and then came back, worked a little bit as a professor at University of Montreal in Montreal, but was then very privileged to have been hired by the World Bank, and I spent 25 years of my career working at the World Bank, and for a good part of that, I was the chief economist for health. So I had an extensive experience across the world with that, really every region in the world, except for maybe Latin America, because I didn't speak Spanish. And it happened to be that I overlapped with the period when we had a number of major crises, public health crises, such as HIV/AIDS, SARS, MERS, Ebola, at the beginning of Ebola. I was an economist, and I looked mainly at the health system side of things and the financing. So I'm not an epidemiologist. I'm not although I have a medical training, I'm not a disease epidemic specialist. So I'm more on how systems respond to these kind of crises. And I was hired in the bank, which I think is very relevant to what we're seeing now. I was hired in the bank in 1990, right at the cusp of the collapse of the Soviet Union. My first country there was Poland, Hungary. I worked a little bit in Russia, Czech Republic, and I saw those countries go through really a shock that we will come back to at the end of our conversation here a little bit, because what we're seeing now, it starts with the virus, but it's not going to end with the virus. There's a sequel to that, and we'll talk a little bit about that. But why don't I just stop here for a second, as an introduction. I retired in 2013 some people say, well, you didn't retire, you're busy enough, never, but I am actually retired now, and I teach as an adjunct professor at Columbia University and at Mount Sinai, and I do a few things on the side, but I have the luxury right now of having time to think and not having to run around do stuff. So I'm quite active academically now, and I write papers and books and stuff like that, and I don't have to earn a living because I get a pension, which is really a great privilege, quite frankly.
Okay, so since you've been on the other side of these things, and because you also have systems expertise, I'm going to sort of bundle two of the questions we looked at together. And that is, everybody talks about getting to the apex. We all want to know when we get out of this. So the first part of that question is, what does the other side look like? Is it just sort of like an air raid? You lift the all clear, everybody goes back to normal? How do we trust what's going on at that point? How do we, what is coming out of one of these scenarios look like? And the other one is, what are the things we should expect to change? Should we be prepared to come to the airport 2.5 hours early because there's going to be a biometric screening? Are we going to, is our temperature going to be taken there? What are some of the things that we should expect will change, and how do we come out of all this?
Well, if I could get you to just for a moment share a screen that I want to show for a moment.
Okay.
If that's possible, I can just flip on if it's all right, I'll just do a share, and if you'll accept.
Okay, sure. Go ahead.
Okay, are you seeing this screen here?
No. Let me just see. Hold on. Okay, I'm going to put multiple participants can share simultaneously. So try and share.
Okay. If not, then I'll just explain it. Okay, it's no big problem. So I'll just try and share again. You seeing it now?
No.
There.
Oh yeah. Yes, we do.
Okay.
Governor Cuomo.
Yeah, so it's Governor Cuomo. So I think he had a couple of slides I just wanted to show you. It's really important in respect to your question. So what he was basically saying is the big problem we have right now, and that of course influences your question because this impacts on what happens afterward. He's basically saying we have this tsunami, a large wave, okay? And the problem is that the hospitals are in the way, okay? So you got this wave and the hospitals are in the way. And what happens is if we don't stop this wave, the hospitals get crushed. And we're actually seeing that in New York right now. So we're seeing some, particularly New York, US is different from Canada. We have the public sector and we have the private sector, but the public sector is getting crushed, basically. Mount Sinai, where I work, is a private sector or NGO, because actually in New York, many people misunderstand. There actually aren't any private hospitals in New York. It's not, you can't in the state of New York get a license as a for-profit private hospital. It's impossible. They don't license for-profit private. All the hospitals are NGO hospitals, which is not unlike Canada. But here it's split. You got the public and you got the private.
So just to interrupt you, NGO is non-governmental organization, but probably that's the same non-profit.
Yeah.
Yeah.
So
okay.
they don't, money doesn't go back to shareholders. And the public system is the residual. But you have to remember that in New York, even in a case like Mount Sinai, in the main campus of Mount Sinai, about 40% of our patients are non-paying. They're non-paying and they're non-registered. They're not under Medicaid because they don't want to register. We're basically what's called a sanctuary city, and which means that people who live here, you cannot identify them and you cannot force them to do anything. And we get that population. So we have a problem with this as well. But the real is, and so in your question, what does the system look like afterward? Well, it depends if things are getting crushed, okay? And what we're trying to do is, of course, what Governor Cuomo is trying to do. He's saying we got to spread this thing out in such a way that, you know, is it going to be 7, 21 when you hit the peak? And what's going to happen? We have 70,000 beds right now. It's hard to imagine if you're in Vancouver. We have to get up to 110,000 beds, 120, maybe even 130, depending on how big the peak is. And if we get up to there, we'll be able to deal with the load.
My wife this evening just saw the latest heading, which is that the ambulance service in New York is right now basically having to slow down responses to things like heart attacks and other urgent things because they're overloaded. That's just the beginning. We're nowhere even near. You see, here we are now. We're talking about the curve going from March. We're in April here now, beginning of April. We still have all of that to go, okay? And so your question is, what's gonna happen here, okay? Right. And that's very difficult to anticipate because it depends, are we gonna be successful with the containment of bringing this down to here, okay? And that's basically, I just wanted to show you those things because they're easier by slides.
All right, so let me stop you there for 1 second, because our curve looks like where you see the 16,000, the lower dotted line.
Yeah, exactly.
That's what the British Columbia curve looks like.
Absolutely.
More.
And if you can keep it like that, you won't have that crushing of your hospital sector.
Right. So does that mean that they're likely to say to us, you know what, we've got this under control. We think you guys can start opening your businesses again. It's okay for dentists to go back to work. The ophthalmologists can continue to do cataract. At what point at this, you know, because this lower graph, that if we do this isolation right, that goes till next Pesach. So is there a scenario by which they say, okay, we've got this under control, let's slowly turn the spigot back on?
You know, this is the big debate that's raging here in the US right now. And I'm sure it is also in Canada and in Vancouver. I have still family in BC, so I hear every day what's happening in BC, but not to the same extent. But I have people who work who used to work at the Columbia General Hospital, and Bob Lumen was one of my colleagues. So, you know, I'm in touch with Vancouver. I'm more tuned to Vancouver than most other places in the US. The issue there is twofold. Why did we shut the businesses in the first place? You know, you have a virus, and I'll just for a second here, flip forward here for a second to a couple of things. You know, we've had other viruses before, right? We never shut the world down with these other viruses. But the problem with this one is that you have death rates which are mortality times the size of the population, okay? The death rates with this virus is not very big, okay? So it's 1%, maybe 2%. SARS, MERS were 45% death rate. But that's where the difference is, because the fact that they were more deadly meant that people died and they didn't spread it. The very dangerous part about this infection is that, and you know, just today, I couldn't even prepare that because it just came out this evening. Everybody in the state of New York now has to wear a mask. We're not allowed to go outside without a mask. And what
just interrupting you, that's so that we don't affect the person we're speaking to, not that we are protecting ourselves. Is that what the mask is believed to do now?
Well, I won't tell you what I think of the mask. I'm just telling you what the new law is, okay?
But there was a motivation for the law.
Yeah, well, because it's hard to know, you know, because these things come out and we don't really know. I mean, what they're trying to say to the population, if you wear the mask, you're not spreading it around and you're not, you know, whatever. But the thing is, we can't get the N95 mask because that's reserved for hospitals. And so the problem with that is that the mask that we're getting right now, you can use against dust, but there's not any scientific evidence that it does much good. I don't know if there are doctors among you here. If there are, please jump in, you know, because as I say, I'm not an expert in this particular.
I'm going to save that question because in about a half an hour, we have our local experts who are going to deal with that. But going to that question, let's just go to the question of.
Well, let me just finish two things that you asked, because I want to be sure I address the question you have, because it's actually a very important question. So this has been the issue from the start. Can you stop this thing by doing this shutdown? Okay, and why are we doing this shutdown with something that, on the surface of it, looks a lot more benign than other things we've confronted in the last decade or 2 decades? Well, the issue is the 2-week period while you're asymptomatic and you spread this thing. And because of that 2-week period, we have a thing that's called the R naught, which is the rate at which things double. So this virus, although it's less deadly, doubles very, very quickly. And if you look at what happened in New York, what basically happened was 7 days ago, Governor Cuomo, this is before we did the draconian shutdown, we were doubling in slightly less than every 2 days. Okay, as soon as we had the shutdown, that period went up to 3 days, 4 days, 5 days. I think it's up to about 7 days now. So we're doubling every 7 days, which means we have actually slowed things down. When can people go back to work? Well, the problem there is we probably didn't have to go off work in the first place if we'd had the test, because then we could have tested. It's likely that a good share of the population was already infected and was mildly symptomatic, and that we already have what's called immunity, natural immunity in the population. But you don't get what we call herd immunity until you get up to around 70%. And so the question now about going back to work, coming back to your question, is once we start doing the serology testing, then we can test people, first of all, critical workers, businesses, other people that have to reignite the economy. And if they test negative, you know they're vulnerable. If they test positive on the serology test, it means they had the virus. You can send them back to work. So you gradually start sending people back to work who are immune already, because there's no reason for them to stay at home. And you can begin selectively sending people back who maybe are not immune, providing they're going back to a safe environment. Okay, so you have those two things. So we could start tomorrow, but the problem is, if President Trump said, go back to work tomorrow, well, that our nod is going to go up again, because we're not there yet. We can't test the population yet. That will happen. I hope it'll happen in the next 2 months, that we're going to test enough people that they can go back to work. And maybe Vancouver will, once the tests are widely available, maybe Vancouver can go back even earlier.
So the way that this would look, if I'm hearing you correctly, is that there would be, a sort of a phased reopening. So
well, that's one way of doing it. The other way of doing it would be, the president likes to make promises. So he'll go out and make a declaration and say, everybody now go back to work. That would not be the right thing to do,
Right. No, well, leaving the U.S. aside,
yeah.
I think.
Well, your prime minister might do the same.
Right, but I think the question really is, a lot of our institutions were ahead of the public declarations. If you look at right now at the public guidance, it's gatherings of 50 people or more, restaurants, nail salons, tattoo parlors, etc. But we shut down the synagogue before the province told us to. Our schools shut down before the public schools shut down. And I realize that everybody has different motivations, but the same is going to be true to a certain extent. I personally think, just as a casual observer, I think that you're going to build public confidence by saying, look, I have a daughter who's waiting to get her braces off, and one of the brackets popped off, and now they're trying to decide, is that an emergency or not an emergency? But at a certain point, the people with cataracts and the people with cavities and the people with
absolutely no, you're absolutely right.
Those people the cardiac patients who need to get more exercise, all those people are going to need to get out. And I'm assuming that Canada, we tend to be a little bit more measured, and there's not the bluster is just not the same here as it is. We don't have a Ford in the mayor's office, and we don't have a Trump at the head of state. So we're sort of in a little bit more measured articulations.
Yeah.
And so, but is that typically how the guidance is going to work? That once the serology tests are up, they're going to slowly reintroduce, and once people say, okay,
that's one scenario. Each place is it's going to be politically driven. That's one scenario. That would be a nice scientific scenario, but as you know, politics doesn't always go along with science. What you have to be a little bit careful about is what we are beginning to see coming out a little bit internationally, is that in some countries where they try to go back to work and whatever too early, or they try to relax the constraints too early, you then get in trouble. Like Britain was a good example. Britain was not very affected, a bit like BC. If you turn the clock back a month in Britain, it was not unlike BC. And then, they didn't do the steps, or they did the steps, but not, not harshly enough. And what happened was now they have a crisis, and Prime Minister Johnson really had to clamp down. So the real trick in the Vancouver case is, do you feel confident? You see, the thing in Vancouver that you would know better, and the experts in Vancouver would know better. But are you confident that on this curve? No, wait a second. On this curve here, are you confident that you're already beyond the peak?
Oh no, we're not. We know. I don't think anybody would make that assumption out here. There's a member of our community on Facebook, Horatio Kemeny, who has a popular Facebook post every day where he looks at he compares, does a side-by-side curve analysis. Right. I think that I'm hesitant to say where we are, but you can see that our rates, the surveillance on this is very poor, and they're only testing people in hospitals and healthcare workers. So we don't really know. We don't know where we are on that curve. But I want to shift us to another question, which I think is going to be interesting, is how does the COVID-19 compare with the Spanish flu of 1918 and 1919?
Yeah, so that's a really, really good question. So when let's look at the Spanish flu, because one of the questions you had that we had also was, is there a chance that we're going to get through this season and then we're going to find ourselves facing a second wave in 2021, or even earlier? It could be earlier. And I think you have some hints about that. I mean, here you have in November 18th, you see how the first wave came along, okay, and then you had a second wave that comes along. If you go back to the Spanish flu, you can see there was the 1819, then there was another one that peaked here, and then you had lesser examples here. When you look at other major flus, so that was the 18 one, but you also had the Hong Kong one, Asian flu. There's been a whole bunch. They all behave about the same thing. It's quite rare you only have one peak. And the only time you really have just one peak are cases like SARS or MERS, which have a death rate of around 40, 50%. And so you kill it off and you're able to contain it. These things you can't really contain until you get to herd immunity. And what saves us in most of these other cases is that you have a vaccine. So I think what's going to determine this one is how fast, the vaccine, let's be optimistic and say it's going to be out in 12 to 14 months. If that happens, that makes a big difference, but it still doesn't protect us for next December. Right. And if you want to, I don't know, do you want to move to the other effect with 2018-19?
Sure.
Well, so the question here now is with 2018-19 is, the number of deaths from the influenza epidemic. We don't really know because, people are guessing how many people died back then, but there are three basic estimates. One is that it's 17 million, the high estimate is 100 million, and the medium estimate is about 40 million. And you have to remember the population in 1919 was about short of 2 billion people, and today we're 6 billion, whatever. So it's 3 times as much. But you can see these other ones.
Alex, yeah. Let me just back you up for a second to make sure we understand. Yeah. So you're saying these numbers, the 24.7 million to 39.3 million, is that the estimate for people who passed away in the Spanish flu?
Yeah, these are the ones from 2019. These are, you see the problem is when we were looking back at 2019, we don't have an actual count globally, and so people are estimating things. And there are three papers that kind of estimate things from that time.
Okay, so just whether it's 17 million or
doesn't matter
or twice that amount, are we better able to deal with COVID because we have a much more advanced medical system now? Or if if these same epidemiologists did a projection out, do we think that the world casualty rate, the number of people who will pass away from this virus, is somewhere between 25 and 40 million, or 3 times that, because the world is 3 times more populous?
Yeah, I mean, it's a good question. It's a little bit hypothetical because, you know, if back in 1919 they had actually done containment like we're doing now, which they didn't do, maybe they wouldn't have had those numbers, right? So we're doing things now because we've learned from experience that we've already done, which, you know, is already having an effect. We don't know. I mean, this really shutting things down right now is having an effect. And so if you didn't do that, you know, let's just compare for a second to the, let me just go back to this one. Let's compare to the flus here. You know, the regular flu, normally you have about 23 million cases. You have 100. You have over almost 200 million cases, but you had about in the 2018, I think it was about 23 million deaths. Okay, so you know, you're talking about numbers that are very 2,000, not million. So you're talking about different numbers. That's because we have a vaccine. In the regular flu, the largest part of the population is vaccinated, which means that you have already herd immunity from the vaccine. Okay, just from the vaccine, you got herd immunity. So you're getting the residual. Right. In this one, we don't have a vaccine. We don't have the herd immunity. That's the risk. That's the big problem.
Right. Okay. So I see that. So just by the way, just historically, I don't know if people saw this. There was I think a video going around about the Spanish flu, which was, by the way, called the Spanish flu because everybody else is at war. Everybody else had the flu too. It was just that Spain wasn't at war, so they weren't losing people by lead poisoning. They were losing people by the flu, so they got the name. But Philadelphia decided to hold a parade, and St. Louis shut everything down, and they had massively different outcomes.
Absolutely.
Absolutely. You know, Philadelphia had like 4,000 deaths, or maybe many multiples of that, and St. Louis had barely any. So yeah, I think it makes sense that the social distancing, or I shouldn't call it social distancing, it's really physical distancing. We're trying to do social. I
like that much better, yeah.
Now,
but let me just add to what you're saying, because I think it's very relevant. The big issue then is also the health system, right? Because certainly back in 1919, we didn't have intubation, we didn't have we didn't have assisted breathing and all those sort of things. We have that today. I mean, that's basically what's, you know, in severe cases, that's what's going to save somebody. That being said, you know, the data coming out in New York right now on the respirators and that, it's not good data. You know, the data is basically showing that 80% of people who get intubated and are on a respirator don't survive. So about 20% survive. Most people don't get on the respirator. You know, most people end up getting assisted breathing by putting a mask on with a little bit of something, a little bit of oxygen and whatever, and it helps them, okay? And it helps them enough that they don't have a problem. It's only the very severe cases you have to intubate and actually put them on a machine. The ones who do get on the machine are very severe cases, and they don't do well.
Right. Wow. Okay, so I'm just moving to some of our other questions.
One point that I just wanted to maybe also, because, you know, in Canada is very different from New York. You and I talked a little bit about that on the phone. Why is New York so bad, right? I think it's worthwhile just emphasizing that maybe with your group. We don't know, but we think it has to do with the population density. New York has about 10 million people that live in the city, and then you have another 10 that comes in and out every day. I mean, you know, I'm rounding these numbers up. So we have huge transient population that go in and out in very, very crowded subways. Any of you who've been to New York will know this is, you know, I mean, even at the best of time, this is an infectious petri dish. And then you have behaviors, you know, where people are very social. They find, you know, one of the big problems now with this clamping down is that people who live in New York like the buzz, and they feel, you know, they really get depressed and they feel very lonely when they don't get the bus. And so it's a culture It's all of that stuff. You know, in Vancouver, you like to go hiking in Grouse Mountain and stuff like that. That's very different from New York. We go down to Times Square.
Well, just for comparison's sake, I think Metro Vancouver itself has about 600, maybe at this point, closer to 700,000 residents.
Yeah, you got a problem there.
And then there's always a debate about how many homes are empty and how many are full.
Yeah,
That's another question.
Yeah.
We do have, though, a very direct route with the epicenter. You know,
Absolutely.
China and Vancouver have a very strong overlap. But what's interesting is one of the first cases that was here was not from China. I think the index case here, or if I'm not mistaken, was a case for someone coming back from Iran. And there is a large Iranian expatriate community in North Vancouver as well. But that's, so you're saying that we're likely in a slightly better shape because we tend to be lonely hikers as opposed to social bus takers. Okay, getting back to, but I want your prediction on the borders in the future. Am I going to get a biometric test when I go through the border?
I think that was going to happen anyways. You know, I mean, I think we're heading toward this, you know, okay, the virus kind of sped things along, but, you know, I think it's not just at the border, you know, I mean, that's going to be, you know, cashiers, all sorts of stuff, you know, we're moving to that. I mean, that's the next level of technology. You know, one of your best predictor where things are going to go is Israel. If you look at what's happening in Israel, first of all, they're very effective in the way they do it. They have a crisis now. I'm not saying they don't have a crisis, but they're very effective in dealing with things. It's a complex situation because it's not a homogeneous society. And I'm not talking about Haredim, you know, which is a special case. I'm talking about just generally. And I think you'll see things. I mean, they've been doing biometrics. They've been checking things. They've been, you know, they have cameras everywhere like they do in London. You know, we're used to something being very laissez-faire. I think those days are over.
Mm. Wow.
And well, I mean, not only that, but I mean, you know, Amazon, which, you know, everybody, I mean, you have a Whole Foods store on 4th Avenue. You know, they're moving toward biometric checkouts where you don't even have cashiers. You just pick your stuff up. There's a sensor up in the air, and it has your credit card. And then as you walk through the door, it charges your credit card for what you have in the basket. And you can't hide it under your coat because it knows it's there.
Wow.
So we're heading toward that anyways.
Well, I mean, the other thing, maybe you can speak a little bit about this. There's been so much research. There was that paper that was published in Nature 2 weeks ago about the travel habits of the Chinese. And there was just an article in the New York Times today. I'm sure it wasn't the New York Times who did it. I'm sure it was a group of academics who looked at people's movements based on anonymous cell phone data. And I'm sure they're going to then look at disease patterns based on that. But maybe maybe you just can reflect on us that should we be assuming that there's our movements are going to be tracked and various other vital signs might come into the picture in terms of our abilities to go various places? Are we heading into a dystopian technology mix here? Like where would your prediction be on that?
You know, I mean, I live in a country where, you know, we have a constitution which guarantees a lot of personal rights. Okay, so and you know, a lot of times it's for the better, but you know, there are a few things that are not so great for the better. You know, like the Second Amendment with guns. So you know, there are places which, you know, you can't get away from history, and you know, so there are protections here that are not going to be let go. Canada is, you know, is not as you know, is not as liberal as I shouldn't use the word liberal because that has a different connotation in Canada. But I mean, it's not as you know, it's not as individual rights oriented as the U.S. is, because you know, Canada does accept a lot of collective rights and that sort of thing. So already Canada has, you know, it's unimaginable what Canada has been doing for years with a Medicare card and all those sort of things. I mean, here in the U.S., you know, it took forever to even come, you know, to even get the tax office to communicate with Social Security because they were not allowed under privacy rules. The tax office was not allowed to give Social Security information about whether or not people had paid their Social Security premiums.
Right.
So, but we're heading to that, and quite frankly, you've heard now maybe in Israel, they're already saying, they're going to be tracking people, where they're doing it. They're doing that biometrics, and they're going to be checking what people do. They're going to have access to your phones there. They're going to know who you talk to. So when so as soon as somebody is an infected individual, they'll check all the people that you've been phoning with in the last 10 days, and they'll follow up on them. So these things, I think the days of total personal privacy is over. But that I don't think I think the virus just sped this up. I don't think this is what caused it.
Right. Okay. I'm going to one last important question, because we only have 6 minutes left. And before I even let you go, I just want to thank you. It's been very, very interesting, very educational. Really appreciate your perspective. And once again, thanks to to Stan and Nora Sean for making this connection. I just want to, since economics is your thing, and I can tell you everything from our Chevra Kadisha to our hospitals are desperate for things as simple as masks and gowns and gloves, and the prediction of us running out of latex gloves is a real thing. So how do you see that catching up?
Well, so, it's a very interesting question. I thought a little bit about it before we talked here, because Canada has for a long time, everybody looks at the US and say, what is this America First policy business? We don't like that. What has Canada been doing for years? You've had Canada First policies for centuries. You don't let your natural resources go. You keep your natural resources. You keep the ownership. You keep you keep your wood. You keep your mines. You keep your oil. Okay. Canada has had Canada First policies for a very, very long time. So you're kind of used to that. I think you were asking me what are some good things and some bad things that are coming out of this virus. Well, I think a couple of good things that's coming out of this virus is we're beginning to realize that our health system is a critical national resource. What the heck are we doing outsource? How can it be the biggest and richest country in the world in terms of finances, the US, can't supply masks to its population, can't build ventilators? Why are we going to Ford Motors to build ventilators? Come on, this is a joke.
They both use distance.
I think we're moving toward a situation where certain sectors are going to be reevaluated as to what's considered national strategic sectors. And absolutely, the health sector is going to become a national strategic sector. I'm convinced of that. And the days of buying everything outsourced to a production factory in China, at least in the immediate future, we're going to rethink that, Wow. The problem, of course, is the production cost. But as we're moving more toward robotics and whatever, you can cut the production cost anyways, So that's not, the production cost, you can't justify anymore going to China just because they've got people that they're paying slave labor wages. That's finished.
Wow.
So
it's interesting, because I guess a little investment advice is you're saying that you think that manufacturing is now going to be more globally diversified as a result of this crisis, because every country is going to say, we need to strategically make our own critical medical wear. Of course, the next virus that comes may not target the ventilator.
No, absolutely. But, you saw this coming before the virus, right? Because we've had 4 years of America First policies, and it wasn't about medical stuff. It was about other things. So I think countries are reevaluating whether or not, does it make sense? And I'm not against, I worked at the World Bank. I worked in China. We tried to help China develop whatever. But when we did that, we were not strategically thinking that China was suddenly going to have 80% of our production capacity worldwide and suddenly become the monopoly manufacturers. Nobody was thinking that even 10 years ago. And now that we're seeing the effect of that, I think people are going to rethink that very, very, very carefully.
Well, very interesting. Well, Alex, thank you so much.
Can I end with this? Because you asked me one more question. Sure. I just want to end with that.
Sure.
Here's the crash in 2029. Okay, it happened 10 years after the virus. People are still saying there was a connection. I'm not sure there was. the 2029 crash, the stock market went down about 30%, 33%, as you can see here, from 330 to 260. Hard to imagine, we're up in the thousands now, right? Here's the stock market, Dow Jones, since I think it's 2006. Look,
That's 1986.
so here's the crash in 2009. Okay, and this is the crash now. It's a blip. What are we talking about? People are screaming, you know, I've lost my life savings. What are you talking about? You haven't lost your life savings. You're up here. So, you know, okay, maybe you're sitting on a bad portfolio where all your stocks are the ones who went down the tube. But the reality is, this is not such a big crisis. This is where we're going to have the problem, is the unemployment. Okay?
Yeah, I was going to say.
That's where we're going to know.
Nobody's ever put pause on an economy before, so we don't know what's going to happen.
Yeah, exactly. But this is where we're heading. So, and of course, you know, and the reason why I bring this up is because Canada always follows economically what we do in the U.S. You know, very seldom. You know, there may be a slight bit of a lag period, but don't be surprised, because if you start getting this kind of thing here in the U.S., you will have an employment situation in Canada. And I'm sorry. I mean, I wish it wasn't happening.
No, I don't think there's really anything remarkably different in terms of the way the economy is put on pause. So, Alex, first of all, thank you so much. Really, so appreciated this time with you, and I found you fascinating and with a wealth of information as well. If I could just ask you though to remove your screen share, and also just point out that there are a couple of questions on the chat that we didn't have time for, but if you want to answer them on the chat, I'm sure the participants would really appreciate that.
Okay. And can I just also say that it's really delightful for me to have been part of this, and I wish everybody a Shabbat Shalom and also a Chag Sameach Pesach. You know, really enjoy having, as the rabbi said, do physical distancing, but social connectivity and spiritual connectivity. This is really where we should be heading.
Okay, well, great. Chag Sameach to you, and hope you have a wonderful Pesach. We are now going to switch over to our regular features in this slot, which is Dr. Gil Kimel and Debbi Rosenbaum. I am going to, they are now unmuted and they should be spotlighted. Tried to spotlight them. Gil and Debbi, are you there? Gil? I'm not. Gil? All right. Well, this is, this is what they call on radio dead air. So I'm, Rabbis, okay, here, Gil's rejoining us. Gil, are you back? Gil, are you there?
Yes. Is that better? Sorry, I was able to hear the talk, but I couldn't.
Okay, now you're here. Wait,
okay, so it's actually only me tonight. Debbi couldn't join us, unfortunately.
Your question is, do you have your superpowers without Debbi?
No, I don't, actually. So she just couldn't join tonight. I'm sorry about that, but we can, I was listening to Alex's talk, so very interesting about economics, and I actually read some of the economic stuff too today, so we can do that a little bit at the end too. But I thought we can do as you wish. We can do questions first. I can give a little bit of a presentation on some stuff that I've been reading over the week that people might find interesting, or whatever you like.
Yeah, you said you had a couple of new things. So I would like, you said there was a lot that changed this week, a lot of updates. So I would like your top line things first, and then we'll get to some of the other material as well. And I'll throw one thing ahead because Alex brought it up. New York City apparently made a regulation that you need to put on a mask to go out. There was a video going around about Hungary, and there was a suggestion that the masks don't protect you from others, but it protects others from you. So all right.
So we can talk about that first. We talked a little bit about that last week about the masks, and in the news, and also in the medical reports, the main issue about wearing a mask is that a lot of people don't know how to put it on and they don't know how to use it. But if you know how to use a mask and you do it properly, then it protects you and it also protects others. So like I tell people, if you go to the grocery store and you see everybody wearing masks and goggles, that's great. Because if they have the infection, they're much less likely to spread it, even if they didn't put it on right. But if you're trying to protect yourself and you don't put it on right, then I agree it's a disadvantage, because you may, let's say, go to the grocery store, open up the door to get some ice cream, and somebody could have coughed on it, and we know that then you touch it and then you can touch your face or something, so that's very dangerous. Or you touch the mask, or you eat something while you're in the grocery store. Those are all big mistakes. But I think that the notion of wearing a mask all the time is a good one. And so we talked about it last week, and I think that that's a good thing. The one caveat is that we don't want people in the community to buy so many masks if we don't have any at the hospital, because then we can't treat the sick patients.
But if you're saying it doesn't work anyway, so you might as well wear a bandana.
Well, it works. It
or a
works.
balaclava.
If you're coughing and you're infected, then you're much less likely to spread it to the counter or to the grocery store if you're wearing a mask. And if you're wearing one and somebody's coughing near you, you're much less likely to inhale it if you're wearing a mask. N95 is required, but even a surgical mask offers some protection. So yes, I do think that if you know how to wear a mask and you know how to put it on and off, and you wash your hands before and after, and you don't touch the inside of the mask, then I do think it's beneficial. But a lot of people just don't put it on right. And like the last time I was on a plane was in February, and there was somebody sitting wearing. There was about 11 people or 12 people wearing masks on the plane. One person was wearing it on their forehead. One person was wearing just on their mouth without covering their nose. One person was eating, propping up the mask. So those are all dumb things to do. So that makes it worse. But if you put on the mask before you got on the plane and you don't touch it, then that's beneficial. And in fact, one of the ICU doctors at St. Paul's, he wore a mask when he flew also in February, and he told me that he noticed that he wasn't touching his face because he was wearing a mask. So even if you get that benefit by reminding yourself not to touch your face, then there's a benefit there too.
Okay.
All good questions about the mask. But anybody else have any questions about masks, or should we cover?
No, go bring me to your top line stuff first.
Okay. So there was quite a few questions that I got by email and other interesting topics about, when are we going to get some, the whole world is focused on this. So number one, when are we going to get a vaccine? And what are the key drugs that are under investigation? And what's the deal with the trials? Why can't we just try things? So there was some very good articles about, number one, why it takes a long time for a vaccine. We covered a little bit last week, but I want to emphasize again, because I just think it's really important for people to understand why it takes a long time for a vaccine. And so a vaccine is designed, remember, to protect you from something that you may or may not be exposed to. And even if you're exposed to it, you may or may not get sick. So the vaccine, the most important thing is safety. There should not be vaccines that are given that cause harm. And we saw with SARS-1 and Ebola, there were some vaccines that were trialed that actually made things worse. So that's the key thing for a vaccine. So you want to, when you're designing it, to make it very careful, very deliberate, and high safety margin, but also efficacious. So that's why it takes a long time. And I think even when they say 18 months, there was one author, one person I was listening to today, who's the head of the ICU at University of Pittsburgh, Dr. Angus, who's a world leader in critical care. And he said, realistically, we should think about 3 to 5 years before it's really available in large quantities and definitely safe and efficacious. So obviously we can't live at home for the next 3 years, but I think that that's the way we should be thinking of vaccines, not to get our hopes up that it will be designed, but not to get our hopes up that it's going to be here by the end of 2020. Now, in terms of other drugs, so Dr. Angus also on his talk, he talked about the trials. So there's already, I think, if I remember correctly, close to 500 trials that are already registered in top research centers in the United States. And the main thrust is to try drugs that are already around, because that's much easier than designing a new drug that may or may not work. And on that note, so there was an article in Cell, or was it Cell or Nature? One of the two of them, I can't remember now, that they have completely discovered the molecular biology of both the the human ACE2 receptor, which was already known, but it's right down to the exact protein structure, as well as SARS-CoV-2. So they know exactly how it binds, where the interactions are between the amino acids. And it's different than the interaction between the same receptor and SARS-CoV-1. And it's actually a little bit stronger and better. So that wasn't such a good thing. But the good thing is that they have identified the exact thing. So then there's some hypothesis, well, maybe we can make a molecule that goes into that human receptor and blocks it so that even if you're exposed to the virus can't do anything. Kind of like putting a key into a lock and then breaking the key off. You can't open the door. So that's the idea, but it's going to take a long time to develop those. And in the article, they said that those things usually take around 5 to 10 years to make. So that's going to be lower down on the list, but eventually, if the whole world focuses on it, they'll discover that. But some other drugs like remdesivir, which is Gilead Science drug, and that they tried to use it in Ebola, but it didn't work for Ebola. But the idea is, well, maybe it'll work for this. And the way it works here, just to make sure that I get it straight, because there's so many drugs here that I wrote down. Oh yeah, it inhibits the RNA polymerase. So the idea is that the virus can't replicate. So they're doing trials, but you need, several thousand cases to prove that it works and that it's safe. So it's going to take some time, but I think that, the reports that I read said that they could have some data by the fall. So that would be helpful. Some of the disadvantages are that it's not that widely available and it's only available IV. But still, if it's effective, especially for those patients in the ICU. The more popular one that was also discussed by Trump, and I got a couple of emails about it, was the chloroquine or hydrochloroquine. And so those drugs have been available for a long time. They're used to treat things like malaria and lupus. And it's plausible because it can stop virus replication, and it also increases. Now, I want to make sure that people really listen to this because, there's these things in the news where they say you eat certain things and you change the acidity of your blood. So I want people to be very careful when I'm saying. So this drug is thought to increase the acidity in endosomes, which is how the virus actually gets into the cell. So it does not change the acidity of your blood, and I do not buy any of those things. So you can't change the acidity of your blood. Otherwise, you're not going to be compatible with life. But so this changes the acidity of endosomes, and so the idea is that maybe it'll impair the ability of the virus to replicate. And so it kind of makes sense, but one of the experts, Dr. Harold, who's an infectious disease doctor, says, that they've tried this on so many viruses before and it has never worked. And so maybe it'll be different for SARS-CoV-2 or maybe not. The other problem with it is that, and in Vancouver, we called up one of the pharmacists that we're quite close with in the community, and she said that their pharmacy has completely sold out of the drug because people have been buying it and hoarding it. And so that's not good because it's not fair to those people that have lupus and that have other problems that may really need it and that we know it works. So I would really use caution about buying that drug and taking it home because number one, you're not allowing the people that really needed to get it. And number two, we have no evidence that it works. And if I was a betting man, I would say it's not going to work, because there's so many experts in infectious disease that have looked at these types of hypotheses with other viruses and it never works. So I hope it does. We'll see because they're testing it.
There's someone on the chat who said that all doctors using hydrochlorine and Z-Pak, in New York, all doctors are using hydrochlorine and Z-Pak. And then it helps to avoid, he says, it avoids incubation. Why are we not doing this here? Do you have any intel?
Because there's no evidence for that. And there was one small paper that was published in the journal of, what was it? It was a journal that I had never heard of. Oh yeah, the International Journal of Antimicrobial Agents. So the trial was not randomized, just recently it was published, and it didn't report clinical outcomes such as death. So it wasn't an intention to treat analysis, so they didn't actually know how people did. So if you're not reporting how many people died that tried it, and you're just reporting how many people did well, it's kind of like doing, interventional surgery on people that are healthy. Of course, everybody's going to do well because they didn't have a problem in the first place. So if this drug works, great, but I don't think there's data to say that it is going to work or that people should start buying it as a prophylactic agent for the two reasons that we discussed. So again, just to summarize, I hope it works, but we have no evidence that it works and the trials are underway. And it's going to take a lot of patients for there to be a good signal. Now, sometimes and Brian and Eitan, who may be listening, know more about this stuff than me, but sometimes you see small signals in specific patient populations. So maybe the drug will be helpful in patients that have very mild disease as opposed to very severe, and maybe patients can be categorized. But I think now it's a little bit early to make those conclusive things. Other drugs that are being talked about, the HIV drug, lopinavir and ritonavir. So again, that has been tried, no results yet, but I think that may, we'll see what the trials show. There's another drug that's in Japan called Camelstat, which is a drug that's used to treat pancreatitis. There's some mechanism that's plausible that may work. So those are just 5 drugs that we covered, but there's already like 400 or 500 that are in the works. And like I said, I think that if we're going to find a drug that works, that helps patients, then it's much more likely to be a drug that already exists than to discover a new drug in the short term. So not to be discouraging, but just to be realistic. And above all, we don't want to cause harm. And like we talked about even from the beginning, even those patients in the highest risk category still have an 80% survival. So in these scenarios, we don't want to make patients worse. Any questions on that, or should I go on to the next topic?
Well, there's one question here. I'm going to generalize it a little bit. That is, are we not supposed to see our elderly parents for over a year? This person says, my mom is going to soon need help, and things are precarious with her. Can she not wear a mask, put on gloves, and stay 5 feet away? And this person is also immunocompromised. What are the things that we can do to safely interact? Do you have a sense of, where it's appropriate to take risks, where it's not appropriate to take risks? The BC guidelines right now are, as far as I can tell on the website, 50 people or more is where the problem is. But if we're going to, if you have a friend, a relative who lives on their own, and you want to have just one person for Seder, is that too dangerous? How do you manage those issues, or recommend that we manage those issues?
Well, that's a great question. I think that the interesting thing about this disease is that, North America, we're not the first ones to experience it. So we can look at countries that have had great success. And we touched on this before, but look at Taiwan. I think I actually wrote down the number. Oh yeah, so Taiwan is next door to China. They have a population of about 24 million people. And it's the 5th most common destination from China. Every month, there's 300,000 people that go back and forth for work or travel, whatever. How many cases in total are there in Taiwan? 339. And how many deaths? 5. What did they do differently? As soon as they saw the virus happening, they shut down the borders. Every plane that landed, they had a medical health officer go on the plane and inspect and talk to every patient. And those that were moderate to high risk were quarantined immediately. Those that were low risk had to stay in their house anyway for 2 weeks, but it wasn't as rigidly imposed. Everybody in Taiwan now, because the schools aren't canceled and business is going on, they have to take their temperature before they leave their house. Everybody has to wear a mask. You have to wash your hands. You have to do as much physical distancing as possible. But that is incredible. Only 339 cases and 5 deaths. Give me a break. What could be better than that? South Korea, they've had 10,000 cases and 174 deaths. That's incredible. So I think when we look at these countries that have great success, we can say that what are we doing in BC? Why aren't we following those lead examples? Well, they may have different governments and people have different maybe sense of, one article said different sense of civic duty. But I feel like, if it was up to me, I would impose rigid physical distancing, because that's been shown to save lives, as we can see in these other countries that have experienced the same risk as us. So when I hear that people are a little bit cavalier, and we're getting pictures on our medical chat lines of, big congregations at the beach still, at Jericho Beach. And so it's the people that are doing that may be at low risk, but I hope that they appreciate that then they may transmit it to somebody else who may also be at low risk, maybe their roommate at university or something, who may transmit it to that person's boyfriend or girlfriend, who may transmit it to that person's parent, who's also low risk, but then they spend time with their grandparents.
Let me see if I understand this correctly. And I guess I'm playing with fire here, but what you're telling me is, having Bubby over for Seder is not going to overload the medical system, as long as the people down at Third Beach stop playing volleyball.
Well, it depends who those people at Third Beach interact with, because we know almost with 100% certainty that there's significant community spread in Vancouver. We're just not testing them, and that's one of the things I was going to talk about. We're not following the South Korean example of doing widespread testing, because if you do widespread testing, which is a totally different and outstanding way to control this, is that if everybody could be tested and you could just do a drive-through at all the parking lots, well, then if you're positive, great, you're told to stay home and you have to stay home. But if you're negative, then you're much lower risk, so then you can continue on with your normal daily affairs. So that's how they have been able to really control it. But with respect to, so let's say you have two households. Let's say my dad lived in Vancouver, which he doesn't. I wish he did, but he doesn't. But let's say he was living in an apartment separately, and our family is at home for 2 weeks, and none of us have the illness, none of us have any symptoms, and the same thing for him. So would it be high risk for him to come over? Probably not, because we've all declared ourselves as not having the illness by being apart from each other for 2 weeks. But it all depends how everybody in my house and everybody in his house behaves. So is Max going to play basketball at the park and potentially an asymptomatic transmitter and transmitting it to me unbeknownst to me, and then I give it to my dad? Well, that would be high risk because my dad is in the older category. So I think if Bubby can come over, if that's what you're asking, as long as we're certain that both parties have been separate for 2 weeks and that everybody is not seeing anybody. Now, that's not what the government recommends, but that's the science behind it.
But let's push to, I think, the questions on almost everybody's mind, which is, how do we come out of this? And how do we get to the all clear? So what I'm hearing you say is, we've now more or less been in extreme distance now for moving towards about 3 weeks.
Yeah.
And our community spread has got to have been, I'm certain if New York has flattened the curve, we've flattened our curve as well, because we had less disease and we're in similar measures. And most of us have been to very few places outside of, our walks in the endowment lands and the grocery store. And every time we go to the grocery store, we're probably taking reasonable precautions, and we've got soap and hand sanitizer, and our hands are all, drying out like crazy. And another shout out to 49th Parallel and Arnold Silber for their work in getting that to the community and to shul members. But at a certain point, I would assume that, and I guess I'll push you on this as if you're my elected representative, what I'm looking for is them to say, okay, we've got good serology tests. We're going to start asking, our dentists and our physical therapists, and I don't know who the second tier of critical services are, and we're going to start saying, look, we're managing our frontline defenses of the hospitals are managing. We're going to start to slowly open things back up. Because we'll test those people, we'll know who's got immunity, we'll know who's got who hasn't had the virus, we'll know who's at risk, we'll know who's symptomatic, who's had contact, and we'll start opening that up. Do you know if anybody's planning to do that?
Well, okay, so a couple of things about the test, and this was vividly displayed last night at one of the hospitals. So the test is not 100%, right? So there's people that are tested and it says that they do not have it, but they actually do. So that can happen in about 15% of cases. So when a patient comes into the hospital and we're suspicious that they have it, they're put in a special area of the hospital. And even if their test is negative, they're still there until the following 2 days. Because the reason why that happens is because the test requires a certain amount of virus quantity in order to be amplified, because it's a PCR amplification technique. So you need a certain amount for it to be amplified without going through a more laborious process, because there is a way to really find the minute amounts, but the normal test has a certain percentage. I think it's about 15% of people that are told that they're negative, but in fact they have it. And so those are the ones that we're worried about. So the idea is, like in South Korea, where you have widespread testing and anybody can get tested, then eventually if you'll get picked up and they'll identify you as being a carrier and they'll be telling you to stay home. But what's going to happen in the future is they'll be able to develop a test against the antibodies. So the IgG antibodies, which are the ones that confer immunity. And then if you've been exposed, then you'll have those IgG antibodies, and then we'll know that you had the disease. And that's, like Alex was talking about, herd immunity. So that will be, that's the home run case, but they haven't developed that test yet, and it probably won't be available for a while. But you're right. I think it is stressful for people to be segregated physically and to not have our normal community, and especially for people that live alone, that rely on community support. So there's no right answer, but if you think about the mathematics of it, and I think Bill Gates discussed it probably the best, I think it's probably you need a total of 10 weeks to really do it properly. And I think that if we take shortcuts, it may feel good that we're kind of cheating the virus by doing the things that we need to do, but then you'll always have it festering in the background, and it'll re-flourish if we do not shut it down once and for all. So if it was up to me, I would say we bite the bullet and we follow the science behind it and aim for the 10 weeks, and then hopefully it will really be suppressed and then it'll be over. But if we keep on doing what, like a W curve, we wait, we relax the things, and then it flares up again, and then we have to do another physical distancing, and then it'll be like this for a long, long time until the vaccine is developed. So that would be my approach. And then somebody will say, well, then Gil, if they start opening up the travel, then people will come in from infected areas and there'll be new clusters. Yes, but not if we allow for more aggressive testing. And so that's what I'm really pushing for, is that to make testing more widely available, and for people to get tested regularly, especially healthcare workers, especially people that work in the pharmacy or grocery stores. Those are the people that are most exposed to other people. There should be wide available testing, and that we can immediately isolate those that have an infection of no fault of their own, not that they're doing anything wrong, but that will protect community, that will protect the seniors in society, because this is a disease that is most fatal for older people. And I think that having a light or loosened approach really puts those people in peril. So that's why I'm
I want to actually drill down on that, and then I'm going to go to Kimel for some questions. But there are we've gotten I think it was a week ago, we saw that 12% of the cases in BC were under the age of 40. I'm hearing a number of scenarios where younger people are getting more and more sick. Do you have any? Can you help us sort out the numbers on that in terms of are there in fact people below 60 who are getting very sick with this disease, needing hospitalization?
Yes. So we can look at this in two ways. So in the New England Journal of Medicine, I shouldn't be touching my face, sorry. I'll wash my hands. Set a good example. So in the New England Journal of Medicine in the last week or so, or actually here it's on this, when was it published? March 30th, so less than a week ago. They have the samples, they have a good report about what happened in Seattle, which is, I think, a very good, probably a good approximation for our demographics. I think, I'm not sure, but I think so. So we can go over some of their data. So the people that went to the ICU, the average age was 64, plus or minus 18. 63% were males. And those people that came to the hospital and eventually went to the ICU had symptoms about a week before they came to hospital, 5 to 7 days before. So that's something to keep in mind. And the most common symptoms have not changed since we first met. Cough, shortness of breath. 50% had fever, and 58% had diabetes. Now, so we're talking about the people that ended up going to the ICU. So just to review that again, almost everybody had cough, shortness of breath, half of them had fever, and more than half had diabetes. And I want to talk a little bit about fever because I listened to a very interesting podcast by Dr. Behr, B-E-H-R, at McGill. And he's an infectious disease expert. So he was talking about fever because a lot of people say, well, I have a little bit of fever, I feel feverish. So I want people to listen and really understand what we talk about when we say fever. So fever is a number. It's not a feeling. You have to actually, it's a numerical number. So if you go into the hospital and you tell somebody, any doctor, and you say, I feel feverish, we're not going to write that down. That doesn't mean anything. But if you come into the hospital and you say, last night, my fever was 38.9, and the night before was 38.7, and today it's 39, that is very meaningful. So on that note, I recommend that people have a thermometer because then you actually have some data. So when we say fever, we mean 38 or higher. And as Dr. Baer said, it's kind of like pregnancy. Either you have a fever or you don't. So if you're 37.2 or 37.6, that's not really a fever. We're looking 38, 39, 40. That's what we're talking about. Those are serious fevers, and that's very common. 50% of people had a fever. So that's a very helpful stat. And if you have a thermometer and you actually record your temperature, then that can be very helpful at the hospital, because then we can identify your symptoms. Now, just continuing on that line of patients. So 70%, 75% of those admitted for respiratory failure, which means that they weren't oxygenating, because this is a disease that causes impaired oxygenation rather than impaired ability to get rid of carbon dioxide, because there's two different branches of that respiratory failure pathway. So we're talking mostly or only about patients that have impaired oxygenation ability. So 75% of those that were admitted for that went to the ICU. So that's a high number. And most of them ended up having low blood pressure, requiring special medications to support their blood pressure. And of those that died in the ICU, most of them died within the first 18 days. So these are very, very sick patients. So now if you say, well, you know, what does that mean? So you could think about it that the ICUs in Seattle, and I think we're probably similar in Vancouver, we're only taking patients in the ICU that have a good chance of survival or that are really sick. So having a high mortality in the ICU isn't necessarily something to be surprised about, because those patients are really sick. Those that are doing okay, even if they require some oxygen support, can be in the regular part of the hospital. But the vast majority are just told to go home because they do not have a serious problem with oxygenation. So this is not to cause panic or scare, but these are the numbers in Seattle. So these patients that are having respiratory failure are sick, they're in the ICU, and they usually have another medical problem, but their constellation of symptoms that they present with are the common symptoms.
Okay, so but you were gonna get to the younger folk, or the younger folk.
Oh yes, the younger folk. So now, from what I understand, for St. Paul's and VGH, there has been a couple of patients under the age of 50 in the ICU, but most seem to do well. And I think one of the strategies that they're doing in the ICU here in BC or in Vancouver is that those patients that are found to be on the edge are being taken to the ICU for careful monitoring, because one of the things that's really coming out, and these were in the Italian studies and also in Pittsburgh and in the other ICU, was the other one I listened to, in Bergamo, what they're finding is that people that are coming in with respiratory failure, if they're doing okay on the regular ward, they can really get into serious trouble within an hour or two. So if you can identify the patients that are at higher risk for requiring intubation, it's probably safer to have them in a closer monitored setting in the ICU. But how we're going to predict the younger patients versus the older patients, who needs intubation and who doesn't, I think that's hard to predict. Most patients do well with a little bit of oxygen, and you know, there's devices called CPAP and BiPAP, which some of the listeners may be familiar with, and they can actually be helpful in these situations. But the problem is that they aerosolize the virus, and so it becomes much different in terms of what the healthcare professionals need to wear around them. So we're trying not to use that equipment, but rather to use equipment that does not aerosolize, which means make the virus blow into the air. So it's not like they're coughing on you, but it actually aerosolizes in the air, and it doesn't, and you can catch it much faster. So we want to try to avoid those techniques. But what the Italians have done is they said, okay, well, we'll use those other techniques, and we'll just make the entire area a kind of a contaminated area, and people will wear full body suits with masks. And that has worked very well for them. And that may need to be done in Vancouver, but we're not sure yet. So again, this is a lot of medical information, but the point is that I think, you know, there's young people that get it that have no medical problems, that have been perfectly healthy. There are older people that get it that have very mild disease. But what we do know for sure is that those people that are having respiratory problems, that are having severe shortness of breath, they can require mechanical ventilation in short periods of time. So those are the patients that really we want to see in hospital, and we want to monitor them carefully because we know that with mechanical ventilation, their prognosis improves a lot.
Okay, I'm going to go now to Kimel, who is going to share with us some questions.
Hi, everyone. Hi.
Hey.
Okay, we have quite a few questions coming in. The chat has kind of really exploded here. I'm not sure where to start on this one. I'll start with the questions that have come in from my cell phone first. So this is a good question in terms of BC Children's Hospital. There hasn't been a lot discussed about what's happening at BC Children's. Are they seeing patients coming in who are COVID positive? There is some reporting out of the US today that they've seen a few infants who have passed away from COVID. Is anything being talked about that here?
I don't know what's happening at BC Children's. So in terms of the infants and children under the age of 10, all of the studies, and I'm talking about China, Italy, Spain, France, there are some case of mortality, but it's extremely, extremely low. So I think that's a point of reassurance that people should feel reassured. These are extremely rare cases. Those that are very young that have died, I don't know if their baseline characteristics are known that well. So I would expect that in Canada and the United States, it's going to be very similar statistics. It's a disease of older people. And one of the reports in the Lancet talked about that so this is kind of cool, and the listener may find this interesting. So they're asking, like, why are kids not as susceptible as adults? And one of the hypotheses is that this disease causes a cytokine storm, which is a release of inflammatory mediators in the bloodstream that really cause the lungs to become leaky and cause this syndrome called ARDS, which we talked about in the first talk. But kids seem to be able to apply the brakes to that cytokine storm early on. So the kids seem to be able to say, wow, this isn't helping. Let me turn this cytokine storm off. And that seems to be what's happening. Whereas in adults, they do not have control of the cytokine storm, and the body thinks that it's helping itself by having this inflammatory process, but it's actually causing impaired breathing and VQ mismatch, as it's called, for the lungs. So the air just can't get through the lungs. So I think that theory makes sense. And hopefully it's right, but I think for the listeners, I would say that there's a lot of reassurance that this is a very rare problem for kids under 10, especially for fatality. Now, there was one report, interestingly, what about people that are pregnant? Is there any evidence that if the mom has it, that the baby can get it? And there is. So there was one report that it is, but both the baby and the mother had very mild disease, and they're not sure if it happened during parturition or during pregnancy to the fetus. So I think that remains to be seen. But and I think people that are pregnant need to take care of themselves and be very careful with hand washing and reduce exposures, just because when you're pregnant, it's more stressful on the system in general. But to answer your question, I don't know what's happening at BC Children's. And I think that all the literature that I've read would say that in all countries that have reported, the fatality rate for those under 10, but also under 15 is very, very low.
Great, thank you. We covered a little bit last week on ACE inhibitors, but I don't think we went into a lot of detail about it. We had a question that came in that many hypertensives are on ACE inhibitors for their blood pressure control. Many diabetics use ACE inhibitors for renal protection. Is there any new news regarding mechanisms for increased risk and whether ACE users should switch to alternatives during this unprotected COVID situation?
Yes, great question. So, okay. So the answer is do not stop your ACE inhibitors. And this was from the American Cardiology Society, the Hypertension Society. And the rationale is that a lot, and also, I think also from the nephrology reports too, although I haven't read them, but the idea is that those medications work for patients that have disease. So if you stop it, then you can have a flare-up of your heart failure, of your kidney disease, of proteinuria, etc. So all of the reports that I see say do not stop it. Now, why was there a hypothesis even that you would even contemplating stopping that medication? Well, the receptor that the virus binds to get into your body, into your cellular network, is the same thing that the ACE inhibitor works on. So people thought, well, if you're on an ACE inhibitor, well, then maybe your body's making more of those ACE2 receptors because it doesn't like it that it's blocked. So the body's going to make more of those, and then you're just giving more avenues of entry for the virus into the body. And there are other hypotheses too. Now, if you want to really get into the detail, there is a article. You can just go to nejm.com, New England Journal of Medicine, and there's a lead article on it this week, and you can read about all the molecular biology, and they have all the pictures. But the bottom line is, for those that don't want to read it, and I don't recommend that you read it, do not stop your regular medications without talking to your doctor. Just avoid getting the disease in the first place. But I would, and by all the mechanisms that we talked about, but I would not recommend stopping it because heart failure and kidney problems are serious enough. And so if you're on medications that's working, I wouldn't take a chance on that. Right, Charlie?
Shirley. All right.
Yes.
All right.
Very good question. Very good question. The other thing I would say, Kimel, is people should talk with their doctors before stopping any medication. And even with ACE inhibitors, if they're having new symptoms, they should talk to their doctor before changing any medications. But based on the reports that I've read, all of the societies are recommending not to stop anything.
Wait, I have a question for Charlie.
Yeah,
How's it been to have school at home?
not good.
Oh.
Not good?
You seem to be having a lot of fun. We told him, I'm going to tell a little joke now. We're going to have a little bit of levity. So for April Fools, which we don't usually do anything, but we told him in the morning, we was like, Charlie, school's starting yesterday. But for Max, it only starts next week. So he wasn't very happy with that. So we had a couple of good laughs yesterday.
Oh boy. All right. Okay. So Camille, you want to throw out another question?
Yes. Questions in terms of flattening the curve and the statement today made by Dr. Henry with flattening the curve. So 2 questions on this. The first one being testing is so restrictive now. So there are a lot of cases of presumed COVID in the community that are not included in the count. Do you feel that because she's making this statement based on, documentation from the hospitals, that we still should be concerned and that she's lightening the load, but we really should still, focus on what we're doing?
So she said that the restrictions are lighter?
No, she said that the curve is flattening.
Right. So that's the beauty of this thing. It means that it's working. So people are social distancing enough that the cases aren't exploding. And if we hadn't social distance, it would have been much worse for sure. So I think the point is that we need to continue on this pathway so we don't get into that W situation where we say, oh, it's working, so we can lighten things up and have congregations. And then I think there'll be much more asymptomatic spread. Because remember, the key components that make this disease serious is, number 1, it's extremely contagious, 4 times more contagious than the common cold. And number 2, there's asymptomatic spread. And today even, I printed it up, there's an article in this journal called Morbidity and Mortality Rounds, where there's pre-symptomatic spread. So people eat like 4 to 5 days before they have any symptoms. Asymptomatic spreaders, that's a very big problem, which is totally different than SARS-1 and then Ebola and other infectious diseases. People are usually have serious symptoms and are flat on their back when they have them, so they know that they have it. Whereas this disease, you don't even know you have it. And there's one doctor that I work closely with, and he was tested positive, and he said he had no idea that he had the illness, and he was still going to meetings and meeting with people, and he had no idea that he had any tested positive, and now his symptoms are very mild. So I think, I didn't hear Bonnie Henry's report, but I guess the point is that social distancing works and we have to continue on that pathway.
Okay, great. And in terms of hotspots for COVID and demographic, do you know if the province is tracking where these individuals are coming from and targeting the communities, like, honing in, checking in to make sure people are actually social distancing, or are we not even tracking that? We're just treating patients?
That's a good question. I don't know the answer. I don't know. I mean, one of the areas we were worried about is the downtown east side, where there's a lot of poverty and a lot of people are living in closed shelters and have food insecurity. So they're in lining up for food. So I think that those would be high response, but I'm not sure. I don't know the answer to. I don't know the answer to the question. I think that if we followed the South Korean model, which I strongly recommended, and a lot of the infectious disease experts at St. Paul's and internal medicine people that I work with were emailing each other all the time, wondering why we're not doing more testing. And it could be a problem with the availability of reagents, or it could be a problem, other problems. But I think that the more testing you do, the faster you're going to catch people that have it, the faster they can isolate, and the faster you suppress any new clusters from blooming. So I think that's the point. So I advocate for strong testing, strong social distancing, and then you cut it once and for all, and then it's over.
Gil, I saw that Bill Gates video, and he said that they've now clinically established that you can self-swab.
Yes, great point, Rabbi. I think that's a great idea, because I think there's two problems. Number one is that, just one second. Sorry, guys. So I think that's a great point. So the problem with the swabbing is that you have to go to see a healthcare worker, and the healthcare worker might be exposed if you're infectious, and so they have to keep on changing their personal protective equipment. But Bill Gates worked on that one from Seattle, where they just designed a swab that the person can insert themselves. They have a little video on their phone, and then they just hand it to the healthcare worker after putting it into the container. So that's a great idea, and I think we should definitely do that in BC. It would be very easy to go, through a drive-through. They pass you the device, you put it in your nose, you swab yourself, you put it back, you hand it to the healthcare worker, and you're gone. And you can do many people at the same time. And I think, if I remember correctly, our machine at St. Paul's, we have, like I said the last time, the latest one, the Kovat 6800, and I think it can test 96 samples an hour. So if you do the math, that's quite a few samples per day. And I would advocate that we should be running all the machines at full power and having very liberal testing.
Question regarding family members who return from hospitals. So someone has had a spouse who is receiving medical treatment, not COVID related. What are the risks for that person and the spouse when they're returning home from the hospital? Are we finding a lot of infections coming from within the hospital?
Great question. So, so if we're talking about patients and not healthcare workers, I think that the risk might be, I don't know what the risk is for patients. It's like one of those videos, when the speaker gets distracted. So Charlie, you're doing a great job distracting me. But so for patients that are in hospital, I think that we're being very careful to swab patients that are at any risk to try to identify those that are positive. And I think that it's fair to say that there's a lot of people in hospital that should be in hospital that do not have it, and they're safe to go home. But for healthcare workers, that's a different story, because if you're working in the hospital every day, then should you come home to your family? Should you not? So there's the Italians said that they really advocated for the healthcare workers to live in the hotels near the hospital, and that proved to be very successful. But from a healthcare worker point of view, the healthcare workers that are getting infected, it's all usually a problem of taking off the personal protective equipment and improper hand washing. So what we're doing at St. Paul's and VGH is having experts that are testing people, the healthcare workers, to make sure that they're putting it on, but also taking it off properly, because the problems happen when you take it off. So for instance, if you don't wash your hands between when you take the mask off and the goggles, you're exposing yourself and things like that. So that, I think, will make a difference, to have a monitor there to watch and things like that.
I have Natalie Wiseman on the line, and I'm going to unmute her and ask her to share a little bit with us about. She's an operating room nurse at St. Paul's, and while people were still coming into the call, she shared with us a little bit about the change in procedures that are going on for her. Natalie, I wonder if you would maybe summarize we have a lot more people on the call now. You went to the beach already?
Yeah. It's my background. Look,
Love it.
where I want to be.
Love it.
Yeah. So no, we were practicing. Going to the. We're practicing putting on and off the equipment, just like Gil's saying. Like the anesthesia department is actually at the forefront of in Canada, especially. There's one doctor, Dr. Lockhart, who's an anesthetist that's very involved with leading the Canada actually in how to put on and take on and off the protective gear, and she's been instrumental with other doctors and critical care doctors and anesthetists in how to manage all the gear that we need to wear. And so, like I said before, we practice regularly because as new information comes in, things change, and we need to practice again. So the more we practice, since it's not in our normal daily routine, the better it is. And we practice with different groups of people because we may be working with different people. So that's what we're doing at St. Paul's right now.
But you had mentioned to me that that there are, there's shifting protocols, which are, I guess, the hospital has to protect its most valuable resource, which is you guys. And that means that some of the patient care is slowed down, and some of the patient care, it just doesn't happen as efficiently because there's so much.
No. That
Okay.
patient care is fine, and the hospitals are very empty right now. So there is actually, I would say, exceptional patient care because we don't have very many patients. And we're actually very prepared. I would say we're not very prepared. We're much more prepared now than we were a couple of weeks ago because we've had time for the hospital staff to get prepared to put on and take care of all these patients. It does take a little more time for us to get ready to treat most of these patients, but we do have the time to do that for the most part. We do. And we don't have very many cases that are in ICU right now at St. Paul's. So we don't have any urgencies at all right now. So it does take time to put on and off the PPE gear. And we're trying to, it's a work in progress. We're trying to make everything more efficient and well done there. But as Gil said, most patients have very minimal symptoms, and they're treated well with oxygen and minimal therapies. And then once they have to, if they ever get to the point of going into any sort of critical care setting, then it's that's when it's properly organized and thought out now. We're very well prepared. We don't have that much going on in the hospital right now. That's what I would say from what I saw today.
Have you had to intubate or to treat anybody who's COVID positive?
Not COVID positive, no, but anyone we're intubating now in the operating rooms, we are just taking extra precautions. So I've intubated in the operating room recently, but we just make sure people are out of the room. We assume that people, we assume people are, we don't know what people are. So we try to minimize the risk to the staff. So we only keep people that need to be in the operating room during those high risk procedures. And then once the high risk procedures are done, then people can come back in after a certain amount of time. So that's sort of right now the protocol. But right now we are at level 2 at St. Paul's. And so they're only doing a lot of mainly just cancer patients and emergencies and things like that. We're not doing elective procedures right now at St. Paul's.
Okay, Natalie, thank you for coming on. This was unplanned, and I'm sorry to have caught you at the beach on this one.
No, no problem.
So I'm looking at the time, and I want to wrap up. Oh, well, got Debbi now. Now super.
Now the master's here.
So Kimel, we're going to go make one more question.
I think, can I just say something? I just want to say something about Natalie. So Natalie is really the frontline worker in this. Debbi and I haven't directly seen any COVID patients. And so the people that are in anesthesia, emerge, and ICU, those are the real frontline workers of the healthcare team. And so, so that's why, from my point of view, just making sure that the healthcare workers are protected and have the right equipment, and is so important, I think, so we can support everybody in the hospital.
Well, Nat, we all really appreciate you, and we appreciated you before this, but we really, really appreciate everything.
Yes.
Thank you. Thank you.
I just a couple of things. First of all, take this moment to let everybody know that, of course, Pesach is coming, and that on April 8th at 8 a.m. we're going to have the Siyum for the firstborn. Please, you can email me, text me, WhatsApp me, or anything for for any of your Pesach related questions. You should also know that we now are, all of these things are now going up on the YouTube channel. It's my YouTube channel, but of course I represent the shul, so you'll find usually about 12 hours or so later, these lectures go up on our YouTube channel, as well as our Model Seder, the Jewish history lectures. Various other things are now getting up there, so that if you missed one of these sessions, you will be able to catch them. We are in a bit of a mismatch in terms of days of the week. We've done these on Thursdays. We're going to have to look at when we're going to do the next one. It's probably not going to be until probably around Monday, the 13th. It probably seems to me the most likely time for us to do our next one, just so that we keep this somewhat regular. We will look at that. We're trying to constantly bring in different guests and try and help understand this better. And I just want to say again how wonderful it is to see everyone. And you know, those of you who have your video on, it's good for me to be able to see your faces. I really get a big kick out of it. Also, even those of you who are not sharing your faces, so that we have a good good bandwidth. I know you're there, and it's great to know that. Just a couple other things happening. Tomorrow we have at I think 5:15 is Rabbi Berger's 2020. At 6:15, Rabbi Wilchfort, with better audio this week, is going to do Kabbalat Shabbat. And this week on both the Zoom channel and Facebook Live, we will be doing the musical Havdalah. My sons have been gearing up to, how should I put it, rock the house. So we hope that you join us for that. And so, Kimel, I'm going to go to you for last question.
Okay, thank you. Okay, just a couple last questions. There was someone who we had talked a lot about diabetes and how many of the cases in the ICU are individuals who are diabetic.
In Seattle.
In Seattle.
It's just diabetes as a risk factor, but with the data that I was talking about was the reports from Seattle. So I think it'll probably be similar here, but definitely those that have diabetes are higher risk to go to the
is there any evidence, I mean, if someone isn't diabetic but has a high BMI, is that increasing their risk?
Well, it's not reported specifically, but those people that have a high BMI are just
there's no
data for
COVID,
but I wonder just in ICU in general.
Is there any data on exactly how much weight we're all gaining being so accessible to our own kitchens and not moving around?
Right, but we shouldn't, right? Because we're still allowed to do exercise. We can walk around the block. There's no restrictions on that. You can walk around the block and call people. And I think there's really, in fact, when I went for a walk today, I saw a lot of people exercising. The one thing that I will say about exercise is that, you know, the case number 0 in Italy happened to be a runner. And so they think that person spread it to a lot of people because he was running in close streets. And so runners and people that are exercising, if they're sick, then they have a higher propensity to spread. So all that means is that when you're walking, or if you go on the Arbutus path or whatever, and you see somebody running, then I do think it's really important to stay that, you know, more than 2 meters away. But you should not, there's no restriction from Bonnie Henry that I've heard that we shouldn't exercise. And so there's really no excuse to spend at least a half an hour or an hour a day exercising and taking care of yourself.
Thank you. For many people who may exhibit symptoms but can't be tested because thank God they're not in hospital, there's a question again that came up this week when are those individuals safe to interact with the outside world?
Say that again. You got it?
Yeah.
Okay.
Yeah.
Okay.
Should I answer?
Yes, go ahead, Deb.
So, public health recommendation for someone who's even proven, so confirmed COVID, is 10 days or 14 days after they develop symptoms. So what we're recommending in the hospital, and we're going back and forth on what we should do when patients who are confirmed COVID in the hospital, when to discharge them, when they should stop isolating. Our clinical suspicion is it should be 10 to 14 days after symptoms resolve, other than a cough, because a cough may linger. So, and the infectiousness may be resolved, but the cough may last for weeks. So we're saying 10 to 14 days after being symptom-free. But we're still recommending within Vancouver that people should physically distance themselves, whether they're symptomatic or not, whether they have it or not. So just because you've had confirmed COVID and you now are symptom-free, you should continue to follow the guidelines that we're recommending to everyone about physical distancing. So you can't reintegrate into society from a lack of physical distancing point of view now. You have to follow the same guidelines as everyone else at the grocery store, only going to essential services, whether you've had confirmed or presumed COVID or not at this point in time. Those are the recommendations. So 10 to 14 days after being symptom-free, other than a cough that could persist longer.
Yeah, just to maybe end on a humorous note, somebody just messaged me that the reason it's called COVID-19 is because you're expected to gain 19 pounds on this.
Yeah.
And the one thing I will say also just to our community is all the people that I'm close with in our community and the shul community are really following the guidelines. So that's great. And because it just shows how people are listening to the guidelines and concerned for their fellow community members. And so I think that's a really important thing to emphasize.
Well, once again, thank you to Gil and Debbie and to Charlie for his patience.
Charlie got a guest appearance.
He added some of the human cuteness factor to this adventure. And I once again appreciate everybody for joining us. I want to wish everyone a happy, healthy, and kosher Pesach. And hopefully we will see you soon in many of our different venues.
Thanks, Rabbi. Thanks, Kimel. Thanks, Howard, for organizing.
Thank you.